Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics. This is part 2 of our podcast series about cardiovascular disease risk factors in women with Dr. Jennifer Mieres and Dr. Gladys Velarde. You can find part 1 on the American Heart Association's official YouTube channel or at heart.org/podcast network.
Hello, everyone, and welcome to our podcast today that I'm joined by Dr. Gladys Velarde, and we are going to discuss the recent AHA scientific statement titled Cardiovascular Disease Risk Factors in Women, the Impact of Race and Ethnicity. And this was published in April of 2023. Both Dr. Velarde and I were co-authors, and so it is great to join you today. So I am Dr. Jennifer Mieres. I'm a professor of cardiology. I have been an AHA volunteer for the past 2 decades and have pretty much devoted my clinical career on gaining insights into the sex and gender aspects of cardiovascular disease.
Oh, Jennifer, thank you so much. It's been a pleasure working with you on this important document. I am thrilled to join you here today. What I wanted to mention to you, Jennifer, is that particularly when it comes to Hispanic women, compared when you just look at mortality, I've also had or bad outcomes. I've also had the comment, but we're protected. We're Latinas, we're Hispanic. We're protected because it doesn't affect us too much. And I know that you are aware that, we coined this term as the Hispanic paradox. Right. And that is a very deceiving term. We all recognize that we need more data, right? We need to research these women more. So this phenomenon is really poorly understood, and it's even harder to make sense of with the data that we have, because it often lumps together all the racial and ethnic backgrounds of whether it is Caribbean, Afro-Caribbean, or Indian, mestizo from Mexico, South America. So it is important that these groups are not lumped together, and it's a call for action for more disaggregation of this data when these groups are studied. The study of Latinos carried out by the principal investigator now for years has been Carlos Rodriguez, now in New York. It has been producing some of the, sort of like the quote unquote Framingham study for Latinos, for Hispanics. And so we're beginning to understand things more and more, that they're not all homogeneous. There's a lot of heterogeneity in Hispanic women, and not only racially and ethnically as it relates to risk factors, but potentially with outcomes. And we're beginning to get some data on this that is shining important light in this area. Also, the issue of acculturation. Acculturation and years in the United States of immigrant status for longer than 10 years or shorter than 10 years, just to give you an example of things that we're finding out, that, those that have been born in the United States, Hispanics born in the United States, have higher rates of smoking, for example, than those born in other countries that migrated later to the United States. There are many examples on the literature that we are beginning to unravel. So more research is needed to be able to understand this better. So just like we recognize that there is heterogeneity in Hispanic and Latina women, Jennifer, that there is heterogeneity in the Asian, Southeast Asian community. What do you think about that? We do know that.
So this is an area we definitely addressed in our paper. And it's an area of evolving research because we know that Asian American women who come from the Far East, South Asia, or the Indian subcontinent have varied rates of cardiovascular disease and risks for cardiovascular disease. For example, high blood pressure rates are 30% among Chinese women, 53% among Filipino women. Low HDL and high triglycerides are seen in Asian, Indian, and Filipino women. So it's an area of ongoing research. And I think what we need to do as we see our patients, especially our Asian American women, knowing where there are risk factors and variances from the traditional risk factors or deviations is definitely important. So I think this research that's going on in terms of highlighting Asian women from different parts of the subcontinent is definitely important. We also know that LP little a is emerging as a risk factor in some Asian American women. And so we added this to the paper to be factored in and a call for more research in this area in understanding the unique risk factors faced by Asian American women. And it goes back to the fact that we have been applying the one size approach to risk assessment. And here again, as you highlighted, in the Hispanic population, we need to be careful in understanding the origins whether someone is from the Indian continent, South Asian versus Filipino versus Chinese. And I also think there the family history is important as well, right? To really add that to the entire sort of spectrum or mosaic of risk factors in the risk assessment.
And the importance of race in
Yes.
in the Hispanic community, is not it. We're seeing those differences of a Caribbean ancestry versus Indian ancestry,
Yes.
and beginning to understand that the risk of the Black race in the Hispanic women means higher risk and it's very parallel to Black American women. So very interesting.
And part of the reason for this position statement was to highlight some of these differences. And when we look at the non-Hispanic, Black, or African American population, we see a high burden of cardiovascular disease in Black women, with about 60% of the US Black population having coronary artery disease or cardiovascular disease. And one key risk factor that we sometimes miss, I always say, is hypertension. High blood pressure, with 53% of Black African American women having hypertension. And if we in the medical community are not aggressive in terms of identifying it and treating it, it contributes to the high mortality that we see in non-Hispanic Black women due to cardiovascular disease complications in the United States. So I think, for this paper, looking at the different racial and ethnic groups and highlighting the burden of cardiovascular disease, the burden of cardiovascular risk factors, also the burden of socio determinants of health, or in or Black population or in the Hispanic population, I think need to come to the forefront in the risk assessment.
Absolutely. I think recognizing that what you said earlier is so key, that not one approach fits all. They bring a risk profile that needs to be better understood and better assessed. We still have a long way to go to assess some of these factors, but at the same time, the ones we do know that are there, and we can connect them with real solutions. Non-medical factors um, need non-medical solutions.
Yes.
And those non-medical solutions are not easy for us who are not necessarily at the forefront of health policy, but we can advocate for those things. And we can be the sounding board to advocacy for those non medical factors that need an integrated approach with some health policy changes.
Well, I think it goes along with the American Heart Association's health equity for all, right? And I think as we think of women's cardiovascular health, understudied, underrecognized, underdiagnosed, undertreated, underrepresented in clinical trials, I think that Go Red for Women and Research Goes Red for Women, founded by the AHA, is definitely now enrolling women in clinical trials, but also um, hearing the voice of diverse women and figuring out where research is needed. So I think you're absolutely right. We have a long way to go, but I feel that with Go Red and the American Heart Association and the Research Goes Red, we're making some progress.
Yes, the energy from and efforts of the American Heart Association and the Go Red for Women are to be commended. When we talk about these risk factors, it's not just language, it's not just access to care, is things that extend to environmental factors, right? Environmental factors that affect our communities more so than other communities, especially women that are Black and Brown women. And so those are factors that cannot be ignored. And the work that the AHA is doing is work that I wish was adopted by many more organizations so we can um, penetrate different environments so we can make this a national agenda like the AHA has made it. But I have to tell you that it is a great start. It's more than a start. They've been doing this for a while. And so, but now the commitment for the social determinants of health specifically, it has been loud and clear in everything that the AHA has done. And I couldn't be more proud to be part of the AHA and also to be doing this podcast with you.
Well, beautifully said. I think coming back to what you alluded to before, we in healthcare and in cardiology or in medicine can't solve for the determinants of health. But for us to get to equity of care, it really takes a village. And the partnerships with multiple industries, multiple communities is important. And in that presidential statement, which we alluded to and we highlighted in our statement, the need for community based partnership so we can really hear the voices of the communities, customizing care based on a community need, whether it's a non-Hispanic, Black, African American community, or Latino community, or an Asian American community. And we also highlighted, the need for more specific research, Asian American women, because like Hispanic, they're sort of a lump together and a one size approach fits all.
That is correct. This applies to all women of all different ethnicities and cultures, but we have to educate them all, and we have to educate ourselves on these non-traditional risk factors so to for us to be able to be better providers. And I think that our paper highlights that. We can spend hours here talking about all the other ones, talk about not just environment but mental health, depression, isolation, all those factors that, as I said, require the village that you mentioned, us putting our heads together and summoning all the resources, working with communities to be able to help these the community specific needs. You know that community intervention, even though some people say, well, it's not sustainable, it doesn't, that there are some in community driven research that uses ancillary staff that works with cardiologists and other providers that is really fruitful, like the barbershop hypertension study. Similarly, for Hispanics, there's the Dulce Project. With that project, a real difference was seen, a significant difference was seen in the dropping the hemoglobin A1C in a year time in a nurse managed group where they assembled a group of ancillary work in the community that was bilingual and bicultural. to be able to penetrate that community and instruct that community. And it dropped the hemoglobin A1C from 12.2 to like 8.7 in a year time, just with that intervention, with the community intervention. It did the same for dropping the LDL and dropping the diastolic blood pressure. So community intervention that is culturally appropriate, that is language appropriate, does work. And it worked for the barbershop study. It worked for Dulce, and I'm sure that there are other examples out there. We have to support that. We have to fund those efforts and make them more sustainable with the help of local and federal government. But those are efforts that have more durable effect because you're treating the communities with the community engagement.
Absolutely. And I think as we wrap up, our statement was really added to the presidential statement to say it has to be a multi-pronged approach. We need to continue to raise awareness, but definitely culturally customize awareness, right? We have to be cognizant of language. We have to educate our physicians that we go and the whole healthcare team that women's disease lies along a spectrum, and you have to incorporate a multitude of risk factors, the traditional risk factors, but sex specific risk factors, as well as the social determinants of health. And I would say adding community engagement, as you said, research, and encouraging women of all races and ethnicities to join research trials so we could continue to make progress is definitely important. And advocacy, truly, truly important.
Yes, I couldn't agree with your summary. Your wrap up hits it right on the nail. We need a village to do all the things we do, and that village is full with people who really want to make a difference. Having the pulse of the community that you treat, for all those out there that are listening to us, it's important that we look beyond the traditional risk factors, that we try to measure them the best we can, the non-traditional ones, and see where and try to individualize care within the context of the community that we serve. Absolutely.
So the journey continues. We have made progress. I think, as Dr. Wenger said, we have hit a plateau. But I think by this sort of partnership and really recognizing the patients and our women as members of the team so that what matters to them, where they're coming from, definitely matters. And also, I think incorporating the fact that we now know that discrimination, racism, affects the inflammatory milieu and contributes to accelerated cardiovascular disease, that we definitely, have to sort of hit the pause button to mitigate our biases, treat our patients with dignity and respect, and customize care to improve cardiovascular outcomes, because we know 80% of outcomes is everything other than that medical encounter.
That is so true. And I am so glad that you mentioned, that word needs to be mentioned because it's out there. It affects our communities, and treating our patients with respect, the respect that they deserve, making them shareholders of their decisions, but they have to be informed based on what we're able to provide, and educate them as much as we can, recognizing that where they come from, what have been their life experiences. So yes, Jennifer, you hit it right on the nail.
It has been truly an honor to join you today, to be a co-pilot on this podcast, to really sort of issue a call to action for increasing research as we look at it through a customized care with including the social determinants of health. Um, More research needed, encouraging our women, or Black and Brown women, or Asian American women to definitely join the Go Red for Women research goes red, so we can get more information, and recognizing, as the American Heart Association has shown, that 80% of heart disease can be prevented with early risk assessment, early treatment, lifestyle changes, more research needed, And I think for our colleagues, really incorporating as the social determinants of health to really get equitable delivery of cardiovascular care is important. So I thank you, Dr. Velarde. It has been a pleasure.
It's been my
Onward we go.
honor.
And my honor as well. Oh my gosh, Gladys. Great to see you.
Great to see you, Jennifer. Thank you.
Thank you.
The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, hosts, and volunteers, and are not reflective of any statements or position of the American Heart Association.